Okay, so wonderful to be here today. Thank you all so much for joining us this morning, for making some time to be here. So just some introductions to start before we kick off. So introductions, I'm Dharinee Hansjee. I work across two roles at the moment. I lead the speech and language therapy team at Queen Elizabeth Hospital in Lewisham and Greenwich NHS Trust, and I'm senior lecturer at the University of Greenwich. I actually qualified in South Africa about 25 years ago as a speech therapist and audiologist, and I left for the UK in 1999. Quite a crucial point in the history of post-apartheid South Africa, as healthcare services were tasked with the mammoth job of redistribution of services to make healthcare more equitable and accessible for diverse population groups across the country. So a lot of learning to be had. I've spent 22 years in the NHS as RCSLT National Adviser. I've been involved in a number of work streams, and one of these being the EDI anti-racism subgroup for health education institutes. I believe as a profession, we are transitioning to becoming more culturally aware in practice, but we are not quite there yet. And I see getting involved in webinars and discussions like today a good step in the process towards sharing and learning from each other. So thank you to Tracy for inviting us to speak today. Sharon is my work wife, I like to call her, at the university. We job share, and I am so deeply grateful for meeting her along my journey. I'll leave Sharon to fill you in on her background and the projects she's been involved in.
Thanks, Dharinee, and thanks again to all the committee on the CEN for inviting me to speak today. So I'm Sharon Adjei-Nicol. I'm was born in the UK, so born in Essex actually, to Ghanaian parents, and still have really strong links with cousins and aunts and uncles in Ghana. In terms of my professional background, I worked in the NHS for about 15 years after qualifying in 2004. And then, and I sort of managed to have quite a broad clinical career. I was quite fortunate to work in acute, community, rehab, lots of different settings, and developed kind of, never really quite developed a specialism because I quite enjoy both dysphagia and communication and work, and left the NHS at the beginning of 2019 to work in independent practice. So that's where I've been working part-time clinically in private practice, whilst also, like Dharinee said, job sharing as a senior lecturer at the University of Greenwich. And you know, one of the projects that I've been really heavily involved with in the last couple of years is the British Ghanaian Partnership. It's actually a CEN, but started off as a kind of just a group of us with links to Ghana, just looking at how we can support the Ghanaian speech and language therapy course, which had just started, and kind of developing speech and language therapists in, you know, in a completely different country who don't really have access to supervision or kind of experience that we would have as students and as newly qualified practitioners. So that's been a really interesting project to be involved with, and has kind of brought me kind of closer to understanding this kind of, how do we translate some of what we do to other cultures. You know, it hasn't been a straightforward case of just giving lectures to students in Ghana and supporting clinicians in Ghana, because, you know, the cultural differences are there and do impact. And so I'm really looking forward to talking today a bit more about dysphagia practice, but also linking in with some of the examples from that project as we go through the session. So yeah, thanks.
Okay, so some of the objectives that we have outlined for the session today is to be able, for you to be able to gain an understanding on the terms culture, diversity, cultural competence, and how they apply at a personal and professional level. To be able to apply knowledge of culture and diversity to clinical professional scenarios related to dysphagia practice, to understand implications of poor cultural awareness for patients or service users and colleagues, to be aware of as well as consider efforts within the profession as we transition towards cultural competency.
And so, if you research, there's quite a few different definitions of culture, but I think ultimately what we're talking about is a personal identification that's based on somebody's language, thoughts, their communication style and interactions, person's actions, customs, beliefs, values, all sorts of things that are kind of specific to an ethnic or racial, religious, geographic or social group. So it encompasses, some culture encompasses so many different things, and is something that is core to anybody's identity. It basically, our culture frames how we perceive the world and our experiences. And as healthcare professionals, it's important to think about, because even healthcare is defined through a cultural lens. And if we think about why it matters specifically in the healthcare setting, a person's culture might shape their understanding of their illness and health in general, how they describe their symptoms. Because, if your belief is that you are perhaps, say, being punished for something that you're experiencing, or that you've brought something on, how you might describe it to a healthcare provider might differ based on your culture. Culture matters in terms of the way people might access health care services, or who they might go to, whose opinion they might most respect in terms of understanding their diagnosis. It can impact the actions people take to seek support, their expectations of care, their response to recommendations. And in terms of dysphagia specifically, their eating and drinking behaviours and routines can be shaped by the culture. So these are all really important things as healthcare providers for us to be thinking about in terms of, the impact of culture in what we're doing in assessment and therapy. I want to also think about the definitions of beliefs and values, because they're all kind of linked in, and I've picked a definition from Beckett et al. But again, there's kind of lots of permutations of how you might define beliefs. But what they say is that beliefs are important cornerstones of our existence, acting as a driving force that make us jump one way as opposed to another. Our beliefs shape the way we think, the judgments we make, the perceptions we hold about people, and the companions we choose to spend time with. They're two kind of shaped and an important part of how we define ourselves. Whereas values are kind of linked to beliefs, in the sense that our values are kind of about long-lasting beliefs that we have that we deem particularly important. So we can have beliefs about a lot of things, but then values might take a stronger sense because they're about the beliefs that we deem particularly relevant and important to ourselves. And obviously that is something that's going to be individual to different people. When we think about equality, diversity and inclusion, specifically, in the recent kind of conversations that have been happening, it's important to kind of think about what we're actually referring to. I think equality is about creating a fairer society where everyone has the opportunity to fulfill their potential. And so obviously it applies to lots of different contexts, but in the same way it applies to our service users, our patients, our clients, whatever the term you use, in the sense that we want them to be able to fulfill their potential. And is that possible if we haven't if we don't really have a clear understanding of their culture, their beliefs and their values? Are we supporting our service users to reach that potential? Diversity is about recognising and valuing differences in culture, differences in beliefs. And a way to demonstrate diversity is through inclusion. So that's what we're talking about when inclusivity is about, incorporating and understanding that people have different values, and it's about inclusion, in spite of various differences. So, age, disability, gender, racial origin, religion, etc. The extent to which somebody can feel included, feel involved, feel valued, empowered in society, regardless of those things. And again, it's about us taking that slightly broader view that we might have done about what our role is in what we're doing, you know, not just about providing assessment, management, education, guidelines, etc., but thinking about our client and how we can empower them, how we can make them feel included and involved and value their experiences and their life, their values and beliefs in their lives. So in order to acknowledge and value diversity, really we need to become aware of our own beliefs and values. We need to acknowledge our own biases. And I think, you know, everybody has biases. It's not about, you know, aiming to not have them, but it's about being aware of them, acknowledging them, and understanding that once you acknowledge, it's about thinking, well, what do I do about this? What do I do about this stereotype that I had, or this thought that I had about this person based, you know, based on, you know, pre-existing beliefs or whatever. But, you know, it doesn't make us a bad person. We're humans, and the biases do exist, but this is about being open to self-scrutiny and acknowledging some of the thoughts that we might have. As speech and language therapists, as a profession, it inherently comes with some degree of bias too, I guess, because we've kind of all been trained in a certain way, especially, you know, those of us who've trained in the UK. You know, there'll be some core kind of values and beliefs about the profession that kind of see us through, you know, about in terms of dysphagia, about, you know, what the risk is that we're trying to prevent, and, you know, the best ways to treat what we see. So we're susceptible to what we call ethnocentrism, which is basically a term that means the belief that one way's life or view of the world is superior. But it doesn't, you know, that comes as well with a professional sense that what we've been taught is right, and not necessarily superior, but correct, and you know, and the best way to go about something in terms of management. But we're also susceptible to something called cultural imposition, which is a tendency to impose beliefs, values, and patterns of behaviour on another culture. And again, if we frame this in the context of professional work that we do, this is sometimes that kind of tendency to kind of want a client to kind of go with our recommendation, and we do that with the best intentions at heart, of obviously wanting people to be safe and to kind of reduce risk. But, you know, how much are we thinking about culture and kind of pre-existing patterns of behaviour, and whether what we're recommending does kind of nicely fit in with that. So our beliefs and values as speech and language therapists, you know, have the potential. Then, you know, I'm not even talking about our personal beliefs and values at this point. You know, just the beliefs as a professional identity have the potential to impact our diagnosis and how we respond to clients. But then on top of that, we will have our own personal beliefs or biases, and, you know, they might even impact the expectations we have for clients in terms of what, you know, perhaps you might, because of a pre-existing experience you've had with a client, thinking that all clients from that culture or from that background have, you know, that they all do something, or they all don't comply, or they're all hard to reach, or you know, this kind of thing about can kind of link to our expectations. So yeah, I think it's important to acknowledge not just our own personal beliefs and biases and become aware of that, but understand that, you know, core to any profession is this kind of underlying link to what we've been taught and what we feel is important. So cultural competence then. This is a definition by Campina Bacotti, who's written quite a few really good papers that I encourage you to read if you're interested in this area. She sort of gave a definition about cultural competence back in 1999, about it being the ongoing process in which a healthcare provider continuously strives to achieve the ability to effectively work within the context of the client. And when she's talking about the context of the client, she's specifically referencing the individual, the family, and their community. And I think we can often be really good at thinking about an individual and their kind of individual kind of priorities, but not necessarily thinking about that individual in the context of their family or their cultural community. And I think that this definition kind of really brings that forward. It's not just about the client as their individual person, but family, community as well. And she suggests that cultural competence requires the integration of 5 different areas: cultural awareness, cultural knowledge, cultural skill, cultural encounters, and cultural desire. And then another paper by McCarthy et al. Talks about also cultural competence involving proactive accommodations. If I take all those things in turn to just kind of briefly give some examples, cultural awareness is basically what we've already been talking about, that in-depth self-examination of and understanding your own biases and kind of acknowledging them. So becoming a more aware of your own thoughts, beliefs, and values, your own prejudices, potentially stereotypes as well. Then cultural knowledge is about seeking out information about some other cultures. And I think we have to, it's not about reading a book or, Googling necessarily. Whilst that is helpful, it's also helpful to be really clear that it's very rare to meet somebody who fits into a cultural kind of stereotype, if you like, 100%. So if you were to look up something about a certain community that you're having to work with, and you were to read about what they would normally wear, what they normally eat, how they normally communicate, it doesn't necessarily mean that the particular client in front of you who identifies as part of that community fits that exact kind of definition. So I think when we talk about cultural knowledge and seeking out information, we're talking about seeking it out from that individual, or that individual, from that individual's family, or from that individual's community, so you can understand it for them specifically, rather than necessarily relying on much more broader information that will give you a general idea, but it doesn't mean that that's going to fit that exact person. And I think that's really, really important, that kind of individual variation even within a culture. And then cultural skill is about developing our ability to kind of collect information regarding a client's culture and perform culturally appropriate assessment. It's basically about asking the right questions when we're doing assessment, seeking the right resources, trying to bring the skills that we have already, but linking them in with that person's culture. And that's a skill that we have to, it's an ongoing process. This, the emphasis on this definition is that it's an ongoing process that, never really, we shouldn't ever feel that we're culturally competent now. This should be something that's just continuous. Cultural encounters is about directly engaging with in cross-cultural interactions. So, we should be similar to the cultural knowledge I talked about. We should be seeking out information, speaking to people and finding out, and trying to make that effort to not just necessarily communicate with people that think similar to us, but have those conversations and try and understand more about other people's cultures. But you can only do that if you have more cultural encounters and you speak to different people. And like I said earlier, you don't just sit back and think, oh, okay, I'm speaking to that person who's told me a lot about this community, Black Bengali community, or Africa, South African, or whatever, because that's one person's perspective. So your cultural encounters need to still understand that what one conversation doesn't represent the whole community. And that's something that's come up quite a lot in recent discussions, from last year after the death of George Floyd, and a lot of BAME speech and language therapists being asked to kind of give their opinions about our journeys as speech and language therapists and things. And it's about you might speak to one SLT who's Black, who's had a very different experience to myself, or so it's encounters is still about understanding that individual nature of what you're hearing. And then finally, cultural desire. this is about what is your intrinsic motivation to do all of this. Okay, this process of cultural competence, is it just a tick box exercise that you're having to do because it's part of the agenda right now and it's in the media and you're being encouraged by a manager, or is there genuine care, passion and openness about this? And what Campina Bacoti is saying is that, you know, cultural competence has to come with this, you know, genuine desire to do better, to be better, not just something that you see as something I have to do, and being honest about that. Proactive accommodations, that kind of can be seen as a link in with this, is about, obviously, in what we're doing in our services, being proactive to kind of adjust some resources, adjust leaflets, adjust our communication style, adjust our setting, adjust the times of our appointments, you know, whatever it needs to take to try and, you know, where it's reasonable, accommodate somebody's cultural preferences and cultural needs. So it's about being proactive in making adjustments and being flexible in what you're doing. And in terms of what this means, hopefully by, you know, by us all striving for this cultural competence, what we're going to get out of this is services that are more equitable, and hopefully outcomes that are more equitable across different cultures and service users. We're going to get a more equal service, hopefully in terms of our own dysphagia dysphagia diagnoses. We're going to be more accurate because we're taking the individual's needs much more and being much more specific and tailoring what we're doing so that diagnosis and prognosis are more accurate, potentially more positive as well. We're going to be developing, hopefully, resources through this work. You know, if as a profession we're all striving for this, then hopefully what we get are kind of new resources being developed that encompass more kind of cultural variety, and you know, this will be a stimulation of creativity within the profession, and even research, kind of, you know, to kind of consider when you start going to try and implement this, some of what we talked about already and what we're going to be talking about into clinical practice. What you sometimes find is, oh, no one's done this, or no one's thought about this, or we don't have anything that we can use. And you know, this hopefully, you know, this cultural competence actually can stimulate some creativity and research within the profession. But what I'd say are the key considerations are that, you know, it is a process. It's not an event, and this isn't about ever really getting there or thinking you've got there, but just something that we always striving to do, and that we try and do for everybody. So there's a tendency to think cultural competence only applies when I meet a client that is from a different background to myself, or is a different ethnic origin, or, you know, speaks a different language. But really, everybody has a culture. When we talked about that definition, you know, everybody has beliefs, values, things that are important to them. So this is something we should be doing for everybody that we work with. And cultural competence goes hand in hand with cultural humility. There's been a lot of debate in the literature about the terminology and whether cultural humility is perhaps a better term. But I mean, personally, I think they go hand in hand. What cultural humility is saying is that it shouldn't be so much about knowledge and skills. This should be a lot more about just your individual kind of commitment to kind of bettering yourself, and kind of constant self-evaluation and critique, and willingness to learn and accept that you're never kind of there. So it is part of what we talk about with cultural competence, but what humility is talking about is perhaps that it should be less about knowledge and skills. But I think, you know, if you take both of those terms and kind of approaches, I think, you know, that's a great positive step. And then, just as I've mentioned a few times, you know, variation within ethnic groups, I think we need to emphasize that, you know, there's so much intra-ethnic variation that just by speaking to one person doesn't mean that's how it always will work, or how it will always seem. So yeah, so I hope that's given a bit of an overview and kind of the kind of foundations of what we're talking about. And I'm going to hand over to Dharinee, who's going to put this a little bit more in the context of some of what we do as SLTs.
Thanks, Sharon. So I believe there is an extraordinary wealth of information that can be gained from our global SLT community. And both Professors Cathard and Pillay were my lecturers when I was at university. And reading through their paper on renewing our cultural borderlands, there was the realization that efforts in post-apartheid South Africa needed to be large-scale, population-based innovations, positioning equity that cuts through all forms of practice with the goal to achieve just and fair outcomes. And this paper, which you'll find in the reference list, describes the EPIC framework for equitable population-based innovations for people with communication and swallowing abilities, and highlights how this aligns to the development of curriculum-based interventions. So a model where development, promotion, prevention occur alongside a deep understanding of communities according to their languages, economic systems, as well as cultural and heritage practices. But really trying to look at the principles behind this model of care and scaling it back to the UK, and looking at what are the tools to enable transformation to new territories, to creating culturally competent or culturally aware communities of practice. So according to a number of researchers and papers, a person's cultural knowledge and values create unique beliefs and perceptions that shape their understanding of health and illness, the ways that they access healthcare services, the actions they take to seek support, their expectations of care, and response to recommendations. So these are fundamental components we need to be aware of as clinicians to help facilitate accessibility and responsiveness to culturally diverse communities. How can we translate this grand rhetoric into everyday practice? So there are several ways in which we can do this, which we will go through today, but perhaps raising our consciousness appears to be the first step. So Sharon talked about it a lot, but raising our awareness as individuals and as a collective. So acculturation refers to the cultural and psychological adjustments that need to be undertaken by individuals following contact with another culture. Now, leading a busy service at Queen Elizabeth Hospital means that it's easy to step into this robotic mode of grabbing what we have available to conduct a dysphagia assessment. And in most acute hospital settings, these are the items on the screen, the yogurts, bananas, cakes, biscuits, are usually the food options of choice to go off and conduct a swallow assessment. Queen Elizabeth is a hospital which serves a very multicultural population. So if I'm consciously aware of the individual I'm going to be assessing, then I might be able to engage in practice differently. And how might I have changed this initial assessment? Depending on the timing and the time that we have, I might perhaps contact the family to ascertain likes and dislikes, see if I can't get that information from the individual themselves, see what I can access on site in the hospital, encourage the family to bring in traditional food and conduct a joint lunchtime assessment. If these options are not available, then run through what I have and establish agreement with the individual rather than assume that the food items will be appropriate. Now, this is probably what most of us do anyway, but beyond that, it's important to be aware of the cultural appropriateness of the items, such as, for example, yogurts in dysphagia assessment. So in the Barrichello paper, so they were looking at dietary habits within Ghana. The authors highlight that whilst yogurts and cheeses are not usually part of the Ghanaian diet, there is, however, the the consumption of thick soups and cereal purees, which might be very beneficial if, in the management, assessment and management of dysphagia. And the other aspect to consider is that Woolwich, for that matter, is an area of significant social deprivation. So being aware of individuals' circumstances of obtaining food in the first instance before discussing modification of diet. So raising our consciousness is the first step. So awareness and then action. Now, there are a number of areas to consider when we are looking at the influence of culture on eating and drinking. So where we shop, ingredients we buy, how we prepare food, who prepares food, what we actually eat and drink, where we eat, where we don't eat, who we eat with, the importance we place on food. So in the Boatma, Basadu and Atkins article 2018, also in your reference list, the authors draw attention to the fact that some communities do not adhere to expert dietary guidelines due to their own beliefs and practices, which will impact on dysphagia management. So healthy eating, for example, within Ghanaian culture is defined as eating the right meals, the right quantity, and at the right time. So what constitutes the right meal would differ depending on the culture. So in Ghana, food in its natural raw state is healthy, and being able to eat a variety of different meals infers wealth. Where there's absence of food, it means loss of vital nutrients and body weight. So poorly cooked food is considered quite unhealthy. And if you think of a frail Ghanaian gentleman who is on a puree diet, which may be looked at as poorly cooked and likely to impact compliance to the diet recommendations. The authors outline 3 aspects to consider within food beliefs and practices: the individual, the family, and also the community. At a personal level, it's the individual's preferences, taste, psychological state. At an interpersonal level, the patterns of the household, food preparation, and habits of significant others. And at a community level, the food availability and prices could influence the accessibility of food and food choices. So Sharon's now going to take you through a bit more detail on areas to include within a case history to ensure we obtain the key information required.
Thank you. So some of the questions to consider when you're taking case history, to kind of make sure that we are, as best we can, tailoring the assessment appropriately to that person. So, depending on the setting, whether you can get that information from a relative or the client themselves, but trying to find out, what foods would this person, this family have in a typical day and week. And sometimes hearing this kind of list and these examples can be so disparate to what you perhaps do in your own family, or what your hospital has in terms of their menu, but at least it can kind of get you thinking about what kind of adaptations might be required. So I think just having some really clear examples of what that person has kind of gives you an understanding of what your future dysphagia intervention might need to look like. And asking clients or their relatives, what food are there, foods that they would rarely consume or can't consume for religious reasons. So, for example, as Dharinee said, a lot of people in my family would not have ever had a yogurt. So to then assess them with it, potentially you're going to have some, you might get someone that spits it out. You might get some, but then we might assume that to be, lack of oral awareness, or I don't know, or somebody's not recognizing foods appropriately or something, when purely they've never had that texture or taste before, and that's the very first time, and it's in the context of them being unwell, perhaps a little bit confused anyway with their diagnosis or their acute medical conditions, and then on top of that something completely new in their mouth. So just being aware of that and those staples that we use for assessment. Sometimes it can be more sort of cultural, religious reasons that people, you know, can't have specific foods, or they need to ensure that foods are obviously kosher or halal, etc. Which we're often a bit more aware of that side of things, but just being aware that if you've already got that list of what they would like, that first question of what they typically have, you start to get a sense of, okay, well, I better ask before I present, you know, this banana or yogurt or whatever, you know, if this is going to be okay. I think it's really helpful to, especially when you start planning perhaps for discharge, or if you're working in the community and you're providing guidelines about, you know, modified diets, to ask where people shop for food and drink, because, you know, a lot of people from other cultures would shop in kind of really small, kind of local shops that sell their local food products. So an Afro-Caribbean food store, for example, and the items that you might find there are very different to what you might find in a big supermarket like Sainsbury's or Asda. And, you know, linked with that could be, you know, what I was saying about just asking these questions to everybody, because even somebody who you might think is, you know, is British, and it, you know, I don't need to worry about these kind of questions, but, you know, what about their social economic circumstances? When you're giving recommendations of things that they need to do, they should start trying to eat because they're softer or whatever. So it's still these are questions that are still relevant to lots of different clients. Who shops and prepares the food in your household? So if, you know, for example, if somebody's wife is the main person that kind of does the food preparation and does the shopping, but they themselves hold some specific beliefs about food, like Dharinee suggested, so they, you know, they have the sense that, oh, if it's got to be something that is well cooked, they have to have lots of different consistencies to make sure that they're displaying that they've got kind of access to a wealth of different foods, and that signifies well for, you know. So it's not even just about the client. Sometimes it's like, does the person who's actually doing the cooking, doing the shopping, have specific beliefs that might influence how they follow the recommendations for their loved one? I think asking what a typical mealtime looks like for somebody, you know, in terms of, you know, who's with them, where they are, what time it is, do they have distractions? Are they, you know, some people might sit on a sofa and have their meal daily. Somebody else might say that they sit with their children, so they're sitting on a really tiny little children's table. That's going to affect their posture. You know, it can be anything. But in terms of some specific cultures, they might not necessarily sit on a chair with a back that can make them at 90 degrees. It's quite common in Ghanaian communities, especially the more rural communities, to sit on really low stools. They don't really sit on chairs. So then, you know, suggesting somebody, you know, sits at 90 degrees, it sounds really straightforward. It might not be. There might be some cultures that sit on the floor to eat. And then understanding the kind of environment that they're eating and drinking in. So, you know, we talk about minimizing distractions, or, you know, making sure people don't talk whilst they eat. What does that mean for that person's normal behavior and routine if eating and drinking is actually something that's seen as a cultural thing or a family event that they have to all sit together and talk at the same time about their day? What does it mean for them to feel included in that practice by just us flinging one thing on the guideline about minimize distractions without really thinking about what that might mean? And I'm not saying these things these guidelines obviously come with evidence base and everything, and we know why they're beneficial, but it's just thinking about, do we take that extra time to explain the relevance, to kind of think about what middle ground or compromises that we can think of or kind of support our clients with. So these are some examples of kind of the questions that we should be asking or thinking about asking, and just really emphasising that this isn't something that we kind of pick and choose who we ask these questions to. These are questions that we can consider for all our clients.
So as Sharon was saying, it is not just the experience of illness treatment for some cultures. It's not just a biological, but also a social process, and involves relationship building between services and providers. Clinicians may want to consider who they may need to work with as professionals. Although the person with dysphagia will remain the critical focus, it may require working with families, spiritual leaders in implementation and engagement with assessment and therapy. Within all of this, we have to be fundamentally aware of our communication style and embrace cultural humility within this. So education and explanations using terminology that is accessible is key. So consider education levels and reading ability. Use materials to enhance understanding, and this is quite integral. And an example would be the use of talking maths, for example, in PEG discussions. But do keep in mind the older versions of the tool, which has come under criticism and scrutiny for not being as culturally inclusive in terms of the pictorial representations. But as far as I know, this has now been adapted in the more updated versions. So it requires time to find relevant pictures on the internet, if that's the best way in, for long-term feeding discussions, perhaps taking along a PEG tube to enhance understanding of what is going to be placed and where. Remember that there are models, diagrams, videos that can be used to aid discussions, but do be aware of appropriacy of materials being used. Sometimes to get the best out of your assessment or therapy, you may need a family member or partner or spouse with you. And prep ahead on how assessments may be conducted if you need to avoid contact or palpation of the swallow due to cultural considerations. Bearing in mind the newness of modified consistencies for certain cultures, having some written information can be beneficial. And again, of course, taking into account their ability to read. A relook at the resources to support modified diets is essential. So at QE, we initially designed ITSE-related diet information leaflets in collaboration with the dietitians, input on suggestions to ensure a nutritionally balanced diet. So whether it's level 6 soft and bite size or level 5 minced and moist diet. But what we need to be doing now is consider further the culturally relevant ITSE level suggestions. So this was recently a suggestion posed by a dietitian on Twitter, which would be fantastic to take forward in terms of future project work in this area. I'm going to hand you back to Sharon to talk a bit more about advice and recommendations.
So linking in with what Dharinee's just been talking about and the kind of my previous slides, that, you know, as we think about our advice and recommendations, we can often kind of fall into that trap of using quite generic leaflets that are already there about safe eating and drinking, or, you know, and just really taking that time to link your recommendations to what you've found out in your case history, those questions that I talked about, and kind of thinking about what proactive accommodations, what flexible things, what adjustments you might need to do to kind of ensure that your recommendations lie as close as they can align with that person's culture. So I've talked already about, you know, the usual recommendation we might give about posture and seating, whether that might be appropriate, or you might need, you know, some slightly more in-depth education if you do genuinely want somebody to see if they can change from sitting, you know, like in the photo, to on a chair. You know, why is that, and kind of is that something they're willing to do? When we think about dietary modifications, you know, say we might say fork mash food, or you know, to get somebody to mince and moist, we're looking at mashing with a fork. You've got the guidelines that say, you know, how small they need to, the pieces need to be, to, you know, in terms of fitting through the fork spikes, you know. But it's, you know, even just something as simple as if you're in your community, you often eat with your hands, or if you eat soups, it's with a spoon. Just that can be quite a different context. I do know people, perhaps not necessarily in the UK, but definitely Ghanaians in my kind of my rural community, my family who are living in kind of villages, in much more rural context, who don't own a fork, definitely would not own a fork. They would use spoons for soup, and then most other foods would be with their hands. So just, just be aware. I mean, obviously we're working in the kind of the UK context, but there might be people that we work with who are still, doing things really traditionally in their own homes. And these are things we just need to check. If people need to blend food down for puree, is that something they have access to? Is that a social, like, have they got the economic finances to actually purchase one? And the same thing with feeding utensils. So we might think about adaptive cutlery for some to support somebody's self-feeding, but again, just checking before we're suggesting things like this, whether using utensils to eat is something they would do anyway. And these kind of guidelines and recommendations we're providing, how will it impact on their client's worldview? If somebody's going down to a puree diet, and they're happy to do that perhaps, but have we thought about what that's going to mean for them when they're sitting at a family meal and everybody else is eating with their hands and they're having to now use a spoon to eat their puree? Does it matter to them? It might not matter, but might. And if you understand that's not what they normally would do, then you can have these conversations about how they feel about that, and kind of how it might feel in that context of a big family dinner and things, and just understanding that these are kind of, to us, might seem like quite small recommendations, but can have a really big impact on somebody's individual cultural context and their community. And the impact that kind of, if meal times are a really important part of someone's routine, behaviour, religious celebrations, how might that, some of what we're suggesting, impact that? Sometimes I think in terms of the kind of more specific exercises, strategies that we might give for dysphagia, I think we need to bear in mind that dysphagia practice as a whole has evolved from kind of the Western profession and research that has been done in countries like America, Canada, the UK. So we don't have a lot of literature to go on that's been done with people in other cultures, and it's emerging from as more courses are developed around the world, and obviously South Africa are kind of leads in terms of what African SLTs would kind of go to research. But we still need to acknowledge that and be aware that we don't know that some of what we are suggesting works in the same way with different types of foods, or with different people, and we just need to be aware of that. I don't think, at the end of the day, this is the research that we have, and we want to embrace evidence-based practice, but we have to know what the limitations are if we're translating that evidence base to a different community, and in different foods, different eating and drinking behaviours, different contexts, different postures of eating, all these kind of things. We need to acknowledge that. Was there anything else I was going to say? No, I don't think there was anything else I was going to say on that slide. Thank you, Dharinee.
So what about the profession at large? How do we see cultural competence being linked in? We'd love to hear some of your thoughts of work going on or future projects you might be involved in within this area. And perhaps after the presentation, we can hear some of your thoughts on this. But taking this to a macro level, should dysphagia be included as a public health priority so that it is up there as the highest level of relevant health policy in the country? This was a suggestion in 2019 where members of RCSLT and NHS Improvement met to discuss priorities towards improving outcomes for people with dysphagia. Including dysphagia as a priority allows us to engage with national and international policies on food security. Now, food security refers to food availability, access, utilization, and sustainability. And in the UK, there's the assumption that most people at all times have physical, social, and economic access to the sufficiently nutritious modified diet regimes that we lay out and put in place, which might not necessarily be the case in a number of communities who are struggling to access food, let alone modified nutritious food. In a research cluster of national and international studies called Thrive, dysphagia is reframed within double edges of food sovereignty, and food sovereignty refers to individuals' rights to define culturally appropriate food that is nutritious and safe, and as well as food security. So double edges of food sovereignty and food security. Food sovereignty and security are promoted as basic human rights, and national and international research is being influenced to relate to food and nutrition security. Understanding political, social, spiritual influences is a core competence that should also be an explicit part of the professional curricula. So from a health education perspective, Godsey in 2011 suggested that intercultural interactions and relationships among students, staff, and clients from diverse backgrounds should be facilitated early in speech and language therapy programs to encourage an understanding of multiple cultural perspectives and how these influence therapeutic relationships. So harnessing these learning opportunities may facilitate all students to develop knowledge and skills to deliver culturally responsive services, and may inform and empower students to challenge professional values and practices that reflect dominant cultural perspectives. In a paper outlining the challenges for undergraduate speech pathology students, so this was, I think, an Australian paper, undertaking cross-cultural clinical placements, Trembath et al. In 2004 indicate that the most important components of the students' preparation were their efforts to understand the contexts in which they would work. So they were willing and committed to cast aside preconceived notions and expectations and to approach new contexts with an open mind. This was in keeping with comments by Dilworth et al., who stated that it is not just enough to be multicultural. Students must be prepared to cross cultural boundaries at a conscious level. So through the process of researching the contexts ahead of the placements and reflective journaling during the placements, the students constantly considered their own perceptions and values at a conscious level in an effort to understand themselves better and the people with whom they worked. So this was quite crucial to the success of the placements for all involved. In reality, you might not have the opportunity for a conscious experience on placement for whatever the reason might be after the year we've just had. And therefore, it's about creating an opportunity for the conscious level thinking that the authors describe within curriculum context. So just thinking about how we can create these opportunities. It's more than simply thinking about the person in front of you in a holistic way, but actually developing the conscious level thinking. And at the University of Greenwich, one of the ways we have included cultural awareness in an assessment is via a patchwork of questions based on a case study. So this allows the students to consider the individual, assimilate knowledge on the culture and customs, and illustrate adaptations that they would employ to assessment and therapy accordingly. And then just looking at the RCSLT and some of the key messages from the EDI and anti-racism work stream. So these are just lifted exactly from RCSLT. So we want to see a profession that is at least as diverse as the population it serves. Change needs to be owned by the whole profession. This is such a pertinent point, as if we don't recognize this as an issue, we are not going to own it and address it. And it is not for Black, Asian, and minority ethnic communities to own this alone. So change is actively promoted from leaders in the profession, and cultural competency is embedded across the whole professional journey via changes to student curriculum, the newly qualified framework, the working environment, and future service delivery. Specific to health education institutes, we have been looking at curriculum review and redesign, student experience, workforce skills gaps and training, and admissions and recruitment. Okay, over to you, Sharon.
So, we just want to end by just summarising kind of what this means for us as clinicians. And, you know, I think a summary of what the characteristics of a culturally competent clinician would be is somebody that kind of appreciates cultural patterns and individual variation, you know, understands that every individual comes with their own life experiences and cultural values, beliefs. It's the clinician that engages in cultural self-scrutiny. So it's somebody that is willing to kind of look within at their own biases and willing to try and do something about this in an ongoing in an ongoing way across many years. It's not an end point. A culturally competent clinician needs to embrace evidence-based practice whilst also collaborating with the patient, the service user, as an expert in their own life. And as I said, you know, we have the evidence that we have, but we have to acknowledge its limitations, and then in those gaps, look at the client in front of us as the expert in their culture and think about how we can collaborate to give them the most individualised, relevant care. It's a clinician that understands the disorder within the client's social context, thinking about family, community, as we've discussed, and as we've emphasised throughout, commits to a lifelong process of dynamic and ongoing engagement, and acknowledges that this is something that we may never kind of fully reach, but there's that commitment to that ongoing education and self-reflection. Thank you. That's the end of our presentation. We've got a list at the end with lots of references, but just like to, which we can share with you the references, but just like to give you opportunity for some questions and discussions now. So thank you. Thanks for listening.
Thanks so much, Sharon and Dharinee. That was brilliant. I mean, it just, you know, for me as a dysphagia clinician, just kind of opens up this massive area of things that I, you know, have underappreciated, I think, as a dysphagia clinician. In terms of questions, I've got one or two, but I'd also like to open it up to people who are attending. If you would like to answer a question, I believe you can unmute yourself to ask, but if you just raise your hand, you can ask, or you can ask through the Q&A function, but you can also do it verbally. Also, if you have comments about the presentation, please feel free to raise your hand and comment as well, because I noticed there's a couple of participants who very helpfully left a few comments on what their background is and why they're attending today. So it would be really useful to hear your experiences and your views, some of the questions or comments that perhaps have been raised with, have resonated with you during the presentation. One of the questions that, you know, sort of stuck with me as a Canadian, you know, and I come from a very culturally diverse city of Toronto, where Black, Asian and ethnic minority communities are actually the majority in Toronto, and sort of the white community is the minority. So it's a very different picture. And moving to Scotland, I found it quite a culture shock for me, because I found it not ethnically diverse at all. And I think that's changing, but it was a bit difficult for me to adjust. And it's sort of over the 25 years I've lived in Scotland, I've kind of thought a lot about how that's changed me. And when I go back to Toronto, how that's changed me and how I'm and my awareness of cultural diversity. And it made me think a lot about cultural, about unconscious bias. And I just wondered, you know, from your perspective as lecturers and when you're teaching at the HEIs and teaching students and teaching people to think about cultural diversity, how do we cross this kind of divide from the unconscious bias to the conscious bias? You know, it's about, you know, these really useful tips, you know, Sharon mentioned about the things that we can think about improving our awareness. But sometimes it's almost, we're not even aware of that bias. It's unconscious. And it's, I think it's quite common in dysphagia practice, because certainly when I started dysphagia practice, it's a very limited kind of structured assessment where you might ask very specific questions. And yes, you're incorporating, all right, what you go about as far as what does the individual like and not like. And that's about it. We don't kind of venture beyond to the context within which that individual lives and eats and drinks, and the community they live in and the culture they live in. And so, are there kind of specific ways of kind of increasing our awareness, even to get to that stage where we can start incorporating these questions into our assessments?
I mean, I think it starts with taking that time to self-reflect, so after you've done an assessment, and it could be with any client, but just that kind of extra couple of minutes as you walk away of, what do I know about them and if you can't, and not if you feel like you can't answer that very well, you kind of start thinking, what didn't I ask that I should have done? What didn't I think about? I think sometimes we can go away and feel like we've got loads of information about their dysphagia, their delayed swallow, their reduced laryngeal movement or whatever, but it's kind of walking away and thinking about, what do I know about them and their community, and kind of making myself stop and think, if I don't know, then I obviously just went into my assessment. And I think it's great to even, because the fact that you're stopping to reflect is trying to get out of that unconscious bias, because I think if you don't have if you don't take the time to stop and reflect, then you're constantly in this loop of unconsciousness with it. And if self-reflection is the first thing for me. Dharinee, I don't know what you want to add.
Yeah, I think that's why I feel quite passionate about getting students at student level, getting students to raising that consciousness as a student, so trying to see what we can put in place. And it does require us to be a bit creative, but for them, because I think it's only at that point, as much as we are all drilled with holistic care and looking at the whole person, and the person in front of you is what matters, until you have the exercise of needing to evidence and show how you've adapted and adjusted your assessment and your therapy within, according to Jewish culture or according to whatever it might be. It is only at that point that I think you then cross over. And I think therefore why these sessions like today are just crucial is I was thinking very much the same thing, Tracy, that we're in London, and so there's enough of those multicultural communities, but then there are just so many areas, and I've spent 7.5 years in Somerset. Beautiful, but very, very white British, and so it was a rarity. To see me pop up was a rarity. So I just think it's those sorts of exercises to really cross that boundary into conscious awareness. You have to. It's taking the time to pause.
Yeah, it's one of those things where, and the pause is really important, isn't it? We can get so much embedded into the way that we do our assessment, and it can involve this limited list of things that we ask and consider, and it's about changing something we've always done. And sometimes and that involves thinking and reflecting, and because it's change, and it's change for the better, though, isn't it? It's got some.
Sorry, I just wanted to also add that, even in QE, with the busyness of acute services, community services, you just get into a way of practicing. And we and the team, when they do listen to the webinar, will be smiling, because we had planned a session to relook at all our resources to make it more culturally appropriate, and to just have that discussion of where are we at with our input and what can we adapt, because you need to have those discussions at various points, and it's only when you pause and you look at, and I just feel this is so timely with COVID, because I think you don't have the status quo anymore, and it's a time to reset. So
Yeah.
it's the ideal time to let's just look at where we are.
Yeah, that actually sort of leads quite well into one of the questions from one of the attendees, which I thought was is quite interesting. The attendee asks, what suggestions do you have, your comment on resources, Dharinee, what suggestions do you have for culturally aware assessment items when we are limited at a service level in the hospital to the items you mentioned earlier, such as yogurt, banana, etc.? You mentioned lunchtime assessment, which is a key of course, but thinking about COVID-19 where families can't visit.
So one of the ways around that, actually, I found that it's telephoning and making that contact with the family. Sometimes we found that we could not get families in, but we would pop up, iPads and FaceTime in front of the desk. It worked for some patients, it didn't for others. Some patients, it was far too emotional and far too confusing because they wanted to reach out and kiss their daughter, and and this was not helpful, but in some instances that's what we did. So it was making contact, finding out a bit more about what they enjoy, and then setting up that meal time to via telecommunication and teletherapy. And so that's quite a big area.
Were families able to sort of bring food in, or because I think that is a real challenge for our hospital-based SLTs is, in any situation is to have a variety of foods that accommodate a person. So were you able during COVID-19 to be able to bridge that gap because they weren't able to visit and bring the food in?
Yes, so it will vary, I guess, with different hospitals, and actually varies across different wards. So critical care, they absolutely were not allowing anybody to bring any food in, whereas some of the other general acute wards, and I know this because I had placed a patient of mine on a puree diet and went to review them and heard about the smuggling in of the chicken, and that she was managing more or less a regular diet now. So that does happen. Yes, they were allowed to bring in food.
And in the past, when I've worked in acute settings, what I've sometimes done, if I'm trying to avoid yogurt, for example, is maybe try just like porridge. I think, I know it's not always as smooth as you need it, but just kind of thinking about some of the breakfast foods can be a little bit more kind of across cultures a little bit more. So often looked at that, or just, like Dharinee said, kind of waited till lunchtime. Often on the trolley would be soup, and thicken the soup instead to try and get it to puree consistency. So just thinking, if you're really restricted and there's, you're not going to be able to like have families bring anything within the hospital context, can you wait till at lunchtime to do the assessment, or do it over breakfast, or do it, and just use the foods that might be that your client has said, they do eat, or they would, that would be more familiar to them. And just seeing what you can adapt then. I know it's not always practical because you need to see people at different times, but I think, just that extra consideration of the timing and just allowing you to, rather than get information that's not going to be necessarily realistic or kind of appropriate, just kind of jiggling things around with your day to just because often the actual lunch menus have just a little bit more kind of variety than what you can get in the fridge in the middle of the day is going to be a yogurt and whatnot. So I think sometimes that's helped, but obviously it's also just about asking. I mean, sometimes it's totally fine, and your client might be happy to give it a try. I think it's just the assumption and just going in with some options, just saying. I often say, usually we would have to try you with a yogurt, and that's something I have here right now. Is this something you're willing to try? And if people express a really strong reason for not wanting to, or say, I don't know, what's yogurt, or I never tried it, or whatever, then you think, okay, I might come back, or so I think it's just being honest. Or usually we would try a banana, and this is or usually we'd recommend you do this. How does that fit in for you? What does that sound like? And kind of just being honest. If that's all you have, just having that discussion. Client, it might be fine, but I think it's just that assumption, just going in maybe with people. Sometimes I've seen clinicians not even give a choice, or just give 2 different flavors of yogurt, or but just have that conversation, just say, this is what I've had right now, Is it okay? And if you get used to doing that with everybody, there's no, there's people that don't like yogurts from all cultures, so if we just get into this routine of doing this with all our clients, it doesn't even become a thing anymore. But I totally appreciate that in the COVID context, it might be harder to kind of get that individual's actual meals into the hospital setting, but those are some suggestions.
That's great. Thank you, Sharon. Another sort of interesting question, and I think you kind of partially answered this with the comments about, just ask and question, is this anonymous attendee asked, I've often got this wrong. So I think the attendee possibly means about being culturally aware, being conscious of cultural competency, and she or he have said, have asked, have you got some good examples or honest examples of when you have got it wrong, or when you feel that it has been gotten wrong?
Yeah,
you go, Dharinee.
Plenty of examples, but yeah, just as I said, you just get busy and you just routinely take what's needed, and because of time, very often it's because of you pushed for time that you just think, I'm going to go ahead and do this. But then what I found, so with the particular lady that that I'm thinking about, it actually took more time because what should have happened is contacted the family member and gotten a bit more information and arranged a joint session with her. And by going in, I wasn't able to get too much done from that assessment, and I wasn't able to make any conclusive recommendations or impressions. So at the end of the day, it did just take more time because then I made the call and then we arranged the session, and so we do get it wrong, and I have to say that it's when you do these sorts of sessions and you read around it and you start thinking that you immediately start thinking about your own practice and being quite critical, and realizing, gosh, there's a lot that I need to be tightening up on and refreshing. And so that's an ongoing process, as we've said. It's not being culturally competent as an end point. It's an ongoing journey.
Yeah, I think it's, from the things that come to my mind are the times when I've made these assumptions. So, for example, I might have had one of the examples I have similar to Dharinee. So I worked in Macclesfield in Cheshire as a band 5. So my first job, coming from London, and used to very diverse kind of community, and then went to an area where it's not very diverse, and it helped me kind of recognize when I reflect, sometimes we have biases about what a white British person's culture is. They all have roast on a Sunday, they all enjoy going to the pub, these are, that's the same thing that people do the other way around, but it's the same thing. And I think, I once had a client who, there happened to be an Afro-Caribbean menu at the time. It might not have been it might have been Macclesfield, but it's definitely a community where it was a job I had where it was mostly white British kind of community, not particularly diverse, but I did have a kind of a small pocket of the community that was African Caribbean. So they had a menu in the hospital, and this patient, we didn't offer that menu to everybody. It's only if we saw that the person was Black that they would be offered if they wanted to have a look at the African Caribbean menu. Now, obviously, at the time, you're thinking, well, this is like 10, 12 years ago, why not? And then it turned out this particular client was married to, so he was white British, but he was married to a Caribbean lady, and was kind of really used to Caribbean food, and kind of that would have been his preference for the menu, and just kind of that assumption of what I've been saying, of not just picking and choosing who you do this for and who you ask these questions for. When you see somebody's Black, you see that they're Asian background, or you see that they've written halal somewhere, just ask everybody. And then it's like, but yeah, those are the kind of mistakes that come to mind, of kind of also my biases around what I think the British community or culture is not everybody does those things. So why do we think the same way that everybody who's been Jewish and Orthodox Jewish is going to have exactly the same way that they follow things, like somebody who's Muslim or Bengali or whatever is going to have exactly the same way. We don't, even within our own communities, we don't all do things exactly the same way. So I think we have to reflect on that, and then this assumption that you kind of pick and choose when things might be appropriate, and just doing it for everyone, so you don't make those mistakes of kind of having to then, I was kind of like, oh, because he was like, how comes I saw this lady over there, she was getting this, and which menu's that? And we were kind of like, so I didn't see that menu, and you're kind of thinking, yeah, why didn't we offer it to you? So that's an example of the many mistakes that have come up in my career.
Yeah, I can think of it's also feeling, I think a lot of it from my personal experience, about feeling okay about making those mistakes, because I've had moments where it's been, oh my God, I can't believe I've done that. And I can either bury my head in the sand and try and pretend that didn't happen, or I can embrace that as a learning opportunity and to feel okay with the fact that, like you say, Sharon, we all have unconscious biases. We just have to be okay with them and become conscious of them. And that's the first step towards managing them. And, I can think of a young woman with profound and multiple LD who I worked with many years ago. And I tried her on lasagna for lunch, pureed lasagna, and no chew, no interest in the food. So bam, she was on puree. And that was exclusively down to my assessment of her eating lasagna. And then mum invited me home and said, I'm going to give my daughter rice kheer, and I'd like to see you eat rice kheer, and I'm not going to modify it at all. And I'd like you to tell me that she can't have textured food. And this lady had the most beautiful chew. And I made such a blanket assumption based on one meal that she'd never eaten before, because lasagna wasn't in her repertoire of foods. And I hadn't even asked the question. And for me, it was such a learning opportunity. It was very sobering. And the mum taught me how I just wasn't thinking at all about diversity, likes and dislikes, the variety of foods that we need to observe. And how can I make these assumptions about what people can manage if I'm not watching them eat and drink them in the first place? So there's just, and it's about, like you say, Dharinee, it is that it does take more time. But if we're not taking the time to do this, what are we doing? And are our assessments and management plans actually reflective on what the issues are for this person and this individual if we're not taking the time to carry them out? There's a really interesting question here from Gareth. Do you think we are so focused on reducing / eliminating risk that we overlook culturally significant processes around eating and drinking? For example, optimizing posture or multiple people supporting with eating and drinking where people live in a larger family network.
Yeah, I think sometimes we're in danger of doing that, and I think we've got to when we think, if we're going to bandy around the terms like holistic care and kind of personalized and all of this, then we've got to try and find an alignment with that and that kind of evidence base of what we know is safe, what we think is safe, but acknowledging that we've got to put that for that particular client. So if we just bring the evidence that this is what's the best posture, but like you've just given a really good example, Tracy, like do it for that individual and see if it works and see if it's best. See them sitting on a different bit, eating food on, completely different to the rest of the family. Does that impact their mood? They then eat less because they feel like they're kind of not enjoying the meal and everybody's eating what they used to eat, and is it going to impact on their nutrition? So it's kind of, I don't think what we do is wrong. I think it's just we don't necessarily apply it to the individual enough sometimes, and that we just, so I think we've got some, we've got really good strategies that we use and really good evidence and research and things, but we've just got to make sure that we take that, if it's possible, take that time to see if it does apply in that individual circumstances and balance those risks of somebody becoming low mood, depressed, eating less, all those other balance, those are risks too, and we can't just focus on the dysphagia risk at the expense of those things. Sometimes if it's that dangerous we might have to, but I'm just saying that these are things that we need to think about, like in that individual's context. We need an additional bit of our risk assessment that thinks about the contextual implications, not just the aspirational,
It's so much
yeah.
more, isn't it? It's so much more than aspiration risk. It's the psychological, the social, and we need to be zooming in on that. And I think, again, I'll go back to, we need to start this at education level. So, because I think as speech therapists, we're very trained to, this is what you do, and these are the cranial nerves that you assess, and these are the items that we use, and so we constantly need to be talking to students about the person, about the individual and individualized care. And there's this point that Kerry made about the video fluoroscopy and the items as well, that so that I know we're pretty good at. So being able to say to the person, these are the things that we would be looking at on X-ray. And if we know ahead of time, because that's usually a booked appointment, and so you do have a bit of time there, then we can plan for either their significant other to bring in the things that they would be eating, and coat that with barium and have a look at that on VF. So we've got to be selling and really putting the focus on individualized care. It's too much around aspiration. And Tracy, we could go into another webinar about that.
Oh yeah, this is a real area of interest for us, isn't it?
Yeah.
And actually, it's I so agree. It really, it's one big thing for me. It's not aspiration is an issue. It is not the issue by any stretch. That actually answers, I think, a bit of one of the questions raised here about a person who was recently contacted by a family to arrange a dysphagia initial appointment, but due to Ramadan, they would have to wait for a few weeks before arranging the initial consultation. And this person asks, well, for this particular individual, we were not overly concerned with the risks of aspiration, malnutrition, dehydration. Thus, I was able to accommodate this. What would be your advice on managing clients with high risks? And, for me, it's always, well, the risks of what? Because as you very rightly mentioned, both of you, there are so many risks. And, it'd be interesting to hear your viewpoint, but mine is it's not about we can't eliminate or even mitigate a lot of risks. It's all about balancing costs and benefits, isn't it? And that's what we do. We juggle them constantly. But we can only provide, as the clinicians, the statistical risks. And this is where decision making, this is a kind of bugbear for me when it comes to talking about decision making. It's not my decision. I don't even share in it. It's ultimately the patient's decision. It's their right to self-determination. And they can only make the decision because they're the only person that can balance the statistical risks that I give them with the individualized risks that apply to them. And they're the only ones that can do that. So I'm not sure if you got something to add on that, but.
Not really. I completely agree. I mean, in a situation like that, I would kind of, be giving the client, their family, the information, but just kind of really pretty much just leaving the ball in their court. I think, a religious like ceremony is if that's the core to someone's identity and value, what they believe in, I think, the risk of what a potential, and it's a risk we don't know because we haven't even seen them for the assessment, so it's almost like I think all I would be doing is just saying, you've been referred because, and I would want to come in and try this with you and just to see, but this is something that if you waited it might, but I can, if this is really important to you, then I think just giving them the information and giving them the onus on their court. I mean, obviously it's slightly different if someone doesn't have capacity and all that side of things, but if we're just talking about somebody who's in a family context and is able to kind of give their decision, then I would purely just be giving them the options and just leaving it up to them personally.
Yeah, I agree. And I think that line, risk comes from not knowing what to do, I think it does cover if we can provide the information and guidance and and leave it to when we can get to them, that would be the best way forward.
Thanks for that. That's great. Another really interesting comment from one attendee was, thank you for your honesty. One main learning point for me was doing home visits and realizing the family all ate on the floor. And so the specialist seating was completely unsuitable and the child sat above them all. So that's a really interesting point. Nazrana asks, I feel really inspired moving forward. How do we start in our workplace as SLTs? So where do we start with improving the cultural competencies in our teams? Have you any suggestions for that?
Dharinee will be the one to answer.
We should do a joint CPD because we're about to do the same. So it's about, because teams change and team members change, and so your culture within the team is changing all the time. And so, I think at regular points, just schedule in a CPD session where you just dedicate some headspace to thinking about how, what are some of the issues that we're coming up against, what are the resources that we want to be. So just, because it looks huge there's a lot that we packed in today. And so it looks like, oh, there's lots to do. But if you break it up and make it achievable by having these regular checkpoints with your team, I think that you'll be on the road really to being, a culturally responsive service. Yeah.
And perhaps if you can get some feedback, or ask the client's family or themselves to join a team meeting via Zoom, if obviously with COVID and things, but they can't come in, but just kind of getting that they might, you might have a couple of clients that if you worked with in the past and you just want to see if they're willing to give their opinions honestly about their experiences, might not just be within the speech and language therapy service even, but just in that hospital when they were an inpatient or whatever, and just if they have any comments or feedback or reflections on things that could be done differently, or things that were done really, really sensitively and well, that they I think that's always to be encouraged, getting service user involvement and feedback if you can as well, because and if you're able to get a range of people to give that feedback, even better. But I think sometimes it's we need to hear honestly what we have done that isn't as a service that could have been better from the horse, direct from the horse's mouth, if we can as well. So I think looking at ways that can be done.
Sorry, Sharon, and also colleagues. So if you've got multicultural teams, if you want to be getting input from colleagues just on appropriacy of diet and what you could take down. So if you can't get hold of the family and you just need to be able to get an idea of whether these are going to be suitable, remember that you've also got your colleagues to call on.
What actually I was thinking of, I really liked the dysphagia case history taking slide that you presented and the questions that we could be asking. And I know, I'm not sure about participants today, but a lot of the assessments that we use are not standardized. I work in adults with learning disability, and we adapt a lot of informal assessments and question checklists. And one of the ways I think I'm going to try and incorporate cultural competency into my assessments is simply by adapting these already adaptable and informal assessments. Is why can't we put in questions about cultural diversity within our checklist of questions? For me, I also often find it's an easy way for me to remember is to have it on the sheet, especially when it's something new, because it's so easy to fall into old traps, isn't it, of just asking the same questions all the time. And best way of me getting around that is having it written down until it becomes habit.
Absolutely. I'm the same, need it written down.
Yeah. Interesting question. Someone's asked, does anyone know of any pre-existing dysphagia or IDSI resources that are culturally varied? I think, Dharinee, you'd mentioned something about pending adaptations of IDSI, but does anybody...
I think Kerry's just put something in the chat. So she said, I've put together a website and some template sheets for making IDSI leaflets with examples wider than the typical diet of white British American. These are meant to be done with patients together. That's fantastic.
That's excellent. But that's, if for those who can't see it, swallowskitchen.wordpress.com. So that's swallows with an S, kitchen, all lowercase, all one word, .wordpress.com. I'd be really interested in that as well, Katie. So Katie, I mean, I think you're on the CEN distribution mailing list. If you're not, do you mind tweeting me and I can put you on it? And I'd be quite interested in sending that out to the Dysphagia CEN mailing list, if you don't mind, because I think a lot of our CEN members would be really interested in accessing the resource and sharing resources. But I'd be really interested in that too. Yeah.
Yeah, because there was someone that copied me into a chat on Twitter about this, and I did obviously respond saying I'll be really keen to be involved, but I didn't hear anything more. But this is something that, you know, we probably at our next meeting we can pick up, you know, the HEI subgroup meeting, we can probably raise and see if we can follow that up.
Yeah, because at the moment I don't think there is anything already kind of out there, so it's just a case of constantly individually adapting things. And, you know, it'd be great if there's something that we can all, the resources that we can all share and access, rather than all reinventing the wheel separately. So that sounds great, Kerry. Thank you. So it's a really good start.
Yeah, Paul has left a really nice comment. Thank you to both speakers for your time and thoughts. And she kind of refers back to her discussion about risk. Oh, it was already answered. I'm thinking it's gone now. Oh, I avoid talking of risk completely. If we frame as potential costs and potential benefits, it's more concrete and I think clearer for all. Yeah, it is certainly, risk is quite a loaded term, isn't it? So, and it's something that we use a lot of the time. And I think it's also quite narrow in the sense that, you know, in the discussion that we've had, you know, we appreciate the wider group of risks, but I think as a profession, historically, we've always narrowed it down to aspiration, malnutrition, dehydration. Boom, that's it. And I suppose costs and benefits is another way of looking at it. I think by changing the word, it helps us open our minds to the cultural implications of what we're doing and what we're considering as well. So yeah, there's a lot in the language that we use, isn't there? Yeah.
Absolutely.
That's great. I mean, has anybody else got any questions or comments? It's really interesting stuff that has come in, and just I think everybody can see the chat now. Oh, Sally's put on a recipe book that's quite interesting in the chat. That has a wider range of meals. Is there something through RCSLT, do you know, that we're starting to share resources like this? I mean, is there a subsection in the anti-racism massive part of RCSLT at the moment on all the anti-racism stuff that they're doing that is consecrated to dysphagia, Dharinee?
I think that there is talk of that, but I don't think there's anybody, to my knowledge at the moment, that anybody's that's been assigned to collate the resources. So that's so just last week there was a email from Kamini about meeting as a group, and so I think because we haven't met for a while and I didn't manage to make the January meeting, so I think yeah, we will try and raise this and see if we can, because there is a web page, isn't there, and so that would be the ideal place to share these types of resources. I'll get in touch with them today and just see if we can try and set that up.
That's great, thank you. Another really interesting general comment here. I really resonated with the sentence about this not just being about Black and minority ethnic community responsibility. I feel it's often this feels like it's the responsibility of those who are from ethnic minorities and a lot of pressure. And you know, it's that resonated with me as well. It's an equal responsibility, isn't it? You know, people who aren't in BAME communities are also responsible for promoting the anti-racism agenda. And it's about not being not racist, it's about being anti-racist, which are two very different things, aren't they?
Absolutely.
That's great. That's well, thank you very much. I mean, I think we've just had it's so much food for thought and some great discussion and great questions. Is that another question that's come in? Oh no, that's the one that's already been answered. So that's great. That's fabulous. So if we don't have any other questions, I think what we'll do is try and close on the survey. But what I'd like to do, we still have around 60 participants. I'm going to relaunch the poll. And I just see for those of you people that have attended later on who came in after the 5 minutes, if you can just respond again to see if we have any difference in the people who've attended, because we're all speech and language therapists. Thank you both from a South African SLT now in Dublin. Very thought-provoking. Thank you. The session's been fab. Thank you. That's great. So getting lots of really positive feedback in there. So that's excellent. So thank you very much for contributing. Oh, we've got attendees are now viewing the questions. We're still waiting for some people to vote in, but still a vast majority of speech language therapists, but we have a social care professional and an SLT student. There's I'm not sure if that SLT student is the one that I've been communicating with, but a student at Queen Margaret University has done a really interesting dissertation on the perceptions of cultural diversity within Scotland. So I'm trying to encourage her to publish that in Bulletin. I think it would be a great Bulletin piece, very topical. So, and she's quite keen. So if Niamh, you are here, very interested to kind of discuss it more. Right, I'm going to close that poll. And I think now, I might get this wrong. I don't know if I'm going to, but Derival, I don't know how to start the survey. I don't know if you can start it.
I think it appears when the webinar ends. Yeah.
Perfect. Okay, so you will get a survey. You will get a survey when the webinar ends as a feedback. If you could please, that would be great. So we will have, we'll be downloading attendance information. So we can, with Zoom, it's great because the attendee reports can show when you joined, if you joined, and if you've joined and stayed for the webinar, that means you've attended the webinar as one of our CEN events. And, as a member of the Scottish SLT, the Scottish Dysphagia CEN, you are eligible to apply for one of our bursaries, and we're offering 3 bursaries this year, I believe, correct me if I'm wrong, Derival and Danny, of £500 each. So quite generous webinar bursaries, and those are to fund education courses, but also resources in the field of dysphagia. So, I think it opens it up to a number of resources that you might not have considered applying to the bursary for. So if you are interested and you have attended the webinar today, then those bursaries are open now for this year, and feel free to contact us at scottdysphagiacen@gmail.com is our contact email, and also we have our Facebook page, the Long Scottish Dysphagia Clinical Excellence Network, and we're also on Twitter.